Hello, my name is Dr. Hardi Hassan. I'm a geriatrician from Heartland Hospital, University Hospital, Birmingham. I'm delighted to be here to present to you my poster on PKG and its role during the pandemic. So during this presentation, I would like to talk about the PKG very briefly, and then what happened to the service during the pandemic, and how did we try to utilize the service, the PKG service, then its impact on patients' care. Then we'll go through a discussion and I'll highlight a few points there. So the first thing is talking about the Parkinson's kinetograph. This is a technology that's developed using a watch by the Global Kinetics. It usually uses an algorithm to generally it compares the oscillation in patients with Parkinson's disease to the normal control. So it detects acceleration and deceleration. The acceleration, according to the altitude and the duration of that, will be plotted as tremor or dyskinesia, and also the deceleration can be plotted as immobility or bradykinesia. So these findings are plotted in a report. We have a summary for the bradykinesia and dyskinesia kind of waves, and also some other metrics as well, which would be very helpful for us to look at to understand the patient better. So the first thing I would like to take you through PKG very briefly. In this picture, you'll see that the top figure looks at the waves. Now the top one, the green color wave, is dyskinesia, and if you look at the gray line, the gray line here, that gray line is the normal control, and then any deviation above that is recorded as an abnormality. So the first faint gray line above it is regarded as a normal variation from the control, and then anything beyond that is significant bradykinesia. Similarly, the rule applies to bradykinesia when you look at the normal control and then the first gray line and then the second one. As we go further down with the bradykinesia or deceleration, it indicates severity of the bradykinesia. Now the next step, when we look at this, this is a nice summary. It tells you the fluctuation of the progression of dyskinesia or bradykinesia during the day. And all these vertical red lines are the times set for the dose. So, so when the machine is applied, it's programmed to give the patient an alarm, kind of beep, to indicate the time to take the medication. And as soon as the patient takes the medication, they swap just on the machine. They swipe the watch, and once they swipe the watch, the diamond lines appear. And if you can see with the dose, the first one on the left, the bottom first on the left, you can see all the diamonds on the line, which means that the patient's taken all these medications on time. And the second one is 6 of them were on time. Now, if you have 6 or 5 or 6 data collected from the watch for each episode, that's quite a reliable data to analyze. Going to the next kind of step after we looked at the summary plot is looking at the immobility summary. So immobility summary appears as you can see it on the top right corner. Each dark bar or black bar indicates immobility. So each dot indicates more than 10 minutes of immobility. And as you can see, there's a cluster of immobility in this patient, for example, in early during the day, and also late in the afternoon as well. So this indicates somnolence. And there's with such a case like this, there is 80% concordance with polysomnography. Tremor identification is another metric that we look at. Again, these are dotted one, and it's very easy to realize that with this particular patient, there is a lot of tremor around midday, and then there's another one, another cluster after 4 o'clock until 6 o'clock. There's also a chance to look at the possibility of an impulse disorder, where the patient will be swiping the machine fairly frequently, something that indicates the impulse disorder. So in general terms, if you have more than 200% kind of response rate, you may think about it. And obviously that will usually trigger a discussion with the patient to talk about their behavior and impulse disorder. There's also some data about symptom fluctuation. As you can see in the arrow to the bottom one, the arrow indicates that the dyskinesia here fluctuates from one day to the other. However, the bradykinesia is the bradykinesia plot is fairly consistent. So there are some metrics with that to indicate whether the fluctuation is high from one day to the other or not. So talking about the PKG, when do we request for these kind of tests? This is a slide from the Global Kinetic team, and it generally indicates that if somebody reaches a more advanced stage of the disease, then it is useful to have another tool in your bag to assess the symptom control, both motor and non-motor, as we indicated, the daytime somnolence and impulse disorder. You can probably get some information from the PKG, but the primary aim is to look at bradykinesia, dyskinesia, and the fluctuation of the symptoms. So if you have minimal information, either from the referral or from the patient, sometimes they have difficulty reporting dyskinesia or tremor. In this case, we think that PKG would be a good tool to use. Or sometimes there's a dispute. You can explain to the patient that their symptoms are reasonably controlled. However, they just ask for more. Then a PKG can be the arbiter here, although this is only when it is reliable, when you have reliable data from the report. So the aim is generally to get a comprehensive patient history and also to establish a baseline sometimes. And also we generally use it when we are in a complex stage and we're thinking about changing the treatment to the next level. So how is it done? Logistically, it's very easy. The contract that we had was very easy. We just requested online, and somebody from the Global Kinetic team go to the patient's address. This is basically after taking patient's consent. They contact the patient. They apply the watch for about 6 days here, and then they upload it and send us any report. Very easy to use, very user-friendly as well. So during the pandemic, we came to as for everybody else, we used to have face-to-face contacts with all the patients. Then everything was cancelled, and among them all the complex ones as well. So after the first wave, we returned back to some new arrangements and we started seeing patients. However, we had to prioritize whom we should see because the capacity was reduced to less than half, actually. we used to have a movement disorder clinic as well as a Parkinson's clinic. Both were taken the whole day, seeing nearly 20 patients a day. And then we were reduced to 8 patients a day. So this meant that we had to make a lot of phone calls and also prioritize those ones who need to be seen face to face. And here, the PKG, sometimes we thought that the reports that we had from PKG could be used for a remote monitoring rather than the face-to-face, although we decided to see some of them face-to-face as well. So the project was, the poster looked at the feasibility of and limitations of PKG in the remote assessment of patients with Parkinson's disease. And the objective was to go through all the reports that we have, PKG reports, and to see whether they really had an impact on patients' monitoring and maintaining good clinical care of these patients. So how did we do that? We looked at the clinic database to see how many patients did we contact. And then how many did we see face-to-face, whether these PKG reports were used in these consultations, and did they have any benefit in generally, whether they enhance the patient-clinician discussion regarding their disease control and medication change. So the result was that there was 88 patients who had telephone consultations, and 27 had face-to-face. And we had 22 requests for PKG, and 15 were done. 2 of them had no reliable data, so it has to be ignored. So 13 were reported. Out of those 13, by the time that I looked at the data, 5 of them were still waiting a review, and 8 of them had the consultations either face-to-face or over the phone, and all of the 8 had reasonable discussions and good outcome from those discussions with regards to the management and symptom control. So, for example, I give you this example. This is a 69-year-old patient where phenotypically he was in the akinetic rigid type, and he was on a complex kind of regime of pramipexole, half Sinemet CR, 2 of those at night, and also Sinemet plus 125 milligrams 5 times a day. And so during the previous consultations, this patient always reported his symptoms were not controlled very well, and that he was always freezing and bradykinetic, and therefore there was always a push towards increasing the dose, and he wouldn't comply much with physiotherapy. So we did this PKG, and as you can see, there is a reasonable control of his bradykinesia, not much dyskinesia. There is a bit of a delayed response to the medications, but some dipping, especially early in the morning and after midday. But then, in general, the control was reasonably good. Taking the complexity of his condition and planning for the future, we decided that we should continue with the same regular medication, and he appeared very positive during the consultation. When stressing on physiotherapy and getting things moving forward, he was much more compliant. And then the next one was another man who was 65, who was convinced that he had Parkinson's disease. We've never seen this patient, when he was diagnosed first, but he must have had some tremor, which responded to reticulocyte patch. But every time we saw this patient in clinic, he was dyskinetic, and he wouldn't agree to reducing the dose. So we both agreed to do this PKG, and all came back as you can see within the normal range, except for a lot of dyskinesia. He now agreed to reduce the dose, so from 8 milligram to final 2 milligrams a day. So the 8 milligram is for the cost is £150 a month. However, the 2 milligram is nearly £70 or £80 a month. So this was another one. I think the plan is to go back to reduce the dose even further if we see him face to face or on video consultation. And the next thing would be to go back to the drawing board here and stop the medication and get the diagnosis right first. We don't know what this was, whether this was a dystonic tremor or anything else that responded to the reticulocyte patch. So here during the discussion, I wanted to tell you a secret, and the secret is that this telephone consultation is going to carry on even after the pandemic. We have had some positive feedbacks from patients during the telephone consultations, and some of them did want to have face-to-face kind of clinics. So there is a role for telephone consultation, and it is going to continue, especially with the invent of video calls, and also this PKG that allows us to monitor the symptoms over a much more prolonged period than just a clinic visit, may help to do this more appropriately. Now, when we do that, when we talk about remote monitoring of patients, we have to really look at a few bullet points. So the most important part is that if somebody is self-reporting, they are really quite reliable, especially if they are using a tool to refer to. For example, the UPDRS, especially part 2. Part 2, really the self-reporting part 2 corresponds to the degree of disability, sometimes even better than some of the disability scales that we have. And also the self-reporting also is as good as, in some cases, as good as face-to-face assessments. We certainly rely on the patient self-reporting using UPDRS Part 2 in our clinic, so that all of them are advised to bring a copy of that during the consultation. So here, in my view, a combination of self-reporting questionnaire and also a face-to-face, either face-to-face or video consultation with access to PKG, can fulfill the requirements for a comprehensive assessment. Next thing we have to go and discuss here is the PKG versus in-person assessment. So we initially talked about self-reporting and in-person assessment. Now, looking at PKG and the data that we get from PKG compared to the data that we get from face-to-face assessment is quite it's quite concordant. I mean by that that the PKG can reflect the motor symptoms reasonably well, and most cases who had a PKG have had an enhanced assessment and also discussion with their clinicians to further improve their symptom control. So there is definitely a good role for PKG here to play. Now, it is a non-invasive kind of technique, and the patients usually like it. It can be done as we did, where the patient lives. So somebody goes out and applies the machine to them or the watch to them, or they can also have it done during a clinic visit as well. So you apply, you can have a contract where you will be given the watches and the iPads, and you apply the wash to them, they go home, and then they drop it 6 days later. Now, looking at the role of PKG, now a large study looking at the worldwide, this is a worldwide study looking at PKG recording all across Europe and America and Canada. They looked at how PKG can help to provide the information that will have a positive impact and improve the patient's symptom control. Now, this is a nice study, and you know, it's a nice read as well. So I put the reference in the reference link. Now, in terms of practicality of PKG, PKG is very easy to deploy, and it was generally well received by the patients and the clinicians. However, sometimes, especially with some difficult cases or challenging cases, we have patients who don't understand how to use it, so especially when they have some cognitive impairment. Also, those people who don't want to put it on, so they agree to have it, and then they don't put it on when they're at home. They take it off and they forget to put it back, or intentionally don't provide these data. So they're unreliable. Majority of the reports are reliable, and I think it will improve the patient-clinician discussion, so that it guides some difficult decisions. And the key point here is that PKG has the potential to close the gap between us, the clinicians, in our approach to symptom control. For example, during that worldwide study, there was a clear difference between how clinicians in, for example, France and the Scandinavians were approaching motor symptom control compared to those in America. So in the Scandinavians and France in particular, their patients had better bradykinesia score, meant less bradykinesia, however, more dyskinesias. So they may be more inclined to go for dyskinesia, you know, so acceptable dyskinesia than bradykinesia, whilst in America, they had less dyskinesia and more bradykinesia. So this is something that the PKG can, if you have a plotter or a pictorial plot of symptom in front of you, then we can potentially train the clinicians to aim for the same target. The second thing is that in addition to that, it is an non-invasive test. It can potentially provide reliable data, especially in motor symptoms. So that remotely, so that for some of the patients, especially with transport problems, I mean, I remember so many patients coming to our clinic before. They really suffered the journey coming to the hospital and waiting for transport to take them back home. They spend the whole day in clinic. Basically, they spend about 6 hours in hospital. That was not good for them. And with this, I'll leave you with the references, and thank you very much for your time and listening.